Melissa? Hi, Melissa. Can you hear me?
I can. Good afternoon.
Good afternoon. So we're live on Facebook now, and I'll hand you over control of the meeting so you can get started.
Okay, excellent. Just for quick clarity, I would like our speakers today, if they can turn on their video so we can get started.
Didn't play games?
Okay, have one of our speakers. We are waiting two of our guests. You know, Dr. Anthony is on the call so far. We are waiting Dr. Karpan and Dr. Singh.
I'm Dr. Singh trying to join. Good evening. Hello, can you hear me?
Great. Good evening. Hello, good evening. The call. I'll give him just a few more seconds. Let's give him a minute, and if not, we will proceed with the conference call.
Hello? Hello, can you hear me? Hello?
Hello.
Hello, good evening. This is Dr.
Hello.
Singh.
Good evening, Dr.
Good
Singh.
evening.
Hi. Good evening.
Hi.
We are waiting one more doctor on the call, and
I
so we just give me a few seconds.
No problem.
Dr. Carp. Yes. And so what we should do, I will go ahead now, and as Dr. Carpin gets on, we will proceed with him. So everyone, good evening and welcome to AmCham's conference call, where we will be addressing the coronavirus pandemic and its impact on Guyana's AmCham's Events Committee, and I will be the moderator for this evening's conference call. With me on this call will be Dr. Frank Anthony. He's a former director of Health Sector Development Unit, and he's also a member of Parliament. Dr. AmCham Singh, who is an intern medicine specialist, and we're currently awaiting Dr. Mahendra Karpan, who is a cardiologist attached to Georgetown Public Hospital and the Caribbean Heart Institute. So doctors, welcome to our online live stream, and thank you very much for being with us this evening as we share information with the general public, your views and your professional opinions on this pandemic and its effect on our health care sector. So we have 1 hour for this call, and we will also be taking questions from our viewers. I believe that our chat is open. So if you click on more, the icon mark more, you will see the chat box spread to over 175 countries worldwide, and discussion. Hello.
Hello.
Hi. I think I was cut off just now. My apologies for that. Hello.
Hello, this is Dr. Singh. Can you hear me?
I'm hearing you. I'm not sure if you were hearing me just now.
Oh, I'm sorry. I lost you.
Okay. So I was briefly introducing our 3 doctors that we will have on the call this evening. Dr. Singh, who is an internal medicine specialist, and also Dr. Anthony, who is a member of Parliament, and he was also the former director of Health Sector Development Unit. And what I wanted us to quickly go into is, Dr. Anthony, if you can just briefly tell us a bit about this virus. What is coronavirus? Dr. Anthony?
Yes. Good evening. You can hear me?
Yes, I can hear you.
Yeah.
Okay. Thank you for having me on the program. To your question, I think a lot of people are concerned about what COVID-19. But COVID-19 is actually caused by a novel form of coronavirus. And viruses are not new. They've been around for quite a while, but this particular virus is new. And so this virus is causing a disease that has been named by the WHO as COVID-19. Hello? So the virus itself, if I can go on, what we know from the pandemic that has been evolving, what we know is that this virus is transmitted through droplets and by person-to-person contact. And so some of the things that we have been advocating is to ensure that people wash their hands, because people would come in contact with surfaces that might have been contaminated. And therefore, washing your hands is one of the easiest way of trying to prevent the infection. If you are next to somebody who is infected and they cough, you can get infected as well. And therefore, one way of preventing that is for you to stay some distance away from that person. And the recommended distance is to be at least 6 feet away from that person. There's now a nice fancy term that is being used. It's called social distancing. And that is that you must be about 6 feet away from the next person so that you can prevent droplets from to you and infecting you. Hello? Maybe you can ask some of the other doctors to come in.
One thing I noticed that the general public wants to know what's the difference between this virus and that of other flu and cold virus, such as the influenza and the rhinovirus. What makes this virus different from the others? If I may. Of the presenting signs and symptoms that you can identify with this virus as opposed to the virus? Go ahead, Dr. Singh, we're hearing you.
Yeah, if I may add, one of the major differences between this virus and many of the other respiratory tract type viruses, like the RSV and the flu virus, is that this causes a very lethal pneumonia in a small amount of patients, but it's very rapid, it's very progressive, and there's no known successful treatment. In many parts of the world, we're hearing of different modalities of treating it, different types of medications that can treat it, but no one has been able to come up with a universal regimen of medications or protocols that will treat it successfully. So this symptom that it will cause, called shortness of breath, coupled with a dry cough, preceding dry cough, makes it very different from most of the other viruses that we have encountered so far. In mild disease, milder form of the disease, we'll see people having fever, runny nose, congestion, sore throat, and so on, as in the flu or many other viral conditions. But this quickly progressive shortness of breath with a very destructive type of pneumonia in both lungs is one of the key differentiating factors between the flu and the coronavirus disease called COVID-19. Now, on a previous program, we had a caller who was asking what's so different with this type of pneumonia and the pneumonias that we have had before, because everyone is familiar with pneumonia. Now, most of the pneumonias you hear about are caused by bacteria. So they have pretty well described protocols to treat those types of pneumonias based on cultures, based on empiric therapy and so on. But this pneumonia, called a viral destructive pneumonia, there's no known or acceptable regimen of medications that can treat it as yet.
I know that there is several vaccines.
At this time, there's
several
no
vaccines that are currently in the trials in the trial stage?
It will take approximately 12 months for us to successfully have a vaccine that works, because they have to go through different phases of trials and so on. So we're nowhere near having a vaccine as yet. Lots of trials are going on, lots of efforts around the world are being made to have a vaccine, but we're nowhere near a vaccine. As I said, we don't even have a universally accepted protocol to treat it. In terms, we're hearing of medications like hydroxychloroquine with azithromycin, we're hearing of remdesivir, we're hearing of other antivirals used in different parts of the world with varying degrees of successes. Only today I received a text from a colleague in the US who's an intensivist, and he was saying that hydroxychloroquine is now working very well in those patients, whereas the doctor in France, who is a renowned infectious disease specialist, said he had great success with hydroxychloroquine in a small group of patients. So we're seeing limited success of many of the regimens, but we don't have a universally accepted protocol as yet, while we wait on a vaccine.
So is Guyana healthcare system, what protocol is there in place currently for treating potential patients who will be coming in with severe in the critical stage? What kind of treatment protocol is there? I noticed Dr. Carpen is on with us at this point, so I would love to, for him to come in and give us his views on that.
Yeah, thank you very much for inviting me and for being having me be a part of this this discussion. So I believe out of the three of us, myself, Dr. Singh, and Dr. Anthony, I have the unique pleasure of being part of the public healthcare system a little bit more intimately at this point. And so I could tell you that's where most of our patients will usually end up seeking their care. And while we may have had some early warnings and indications that this thing is going to come our way, we might have been a little bit slow in reacting, in making the right preparations and stuff. Mind you, in the mighty US of A, they have been caught, a little bit ill-prepared as well. And it takes a lot of resources. It takes a lot of, when I say resource, I don't just mean financial resources, but it also requires human resources because it not only takes a toll economically, but also on the personnel that has to be part of the caregiving team. What we have been able to do in the public sector, and I by no means, am I speaking on behalf of the public sector. I'm just sharing my own experience. That we have set up a lot of triage areas for patients who are going to come to the main hospitals, particularly Georgetown Hospital. They are triaged and assessed in terms of their risk level, and then shunted into various places depending on the level of severity in which they present. Mild cases, of course, are asked to self-isolate at home and self-quarantine. Patients who actually need admission, they're institutional quarantine measures. And for those very sick patients that you are asking about, there are certain basic intensive management that applies to these patients the same as any other patient. And we are learning as every day goes by what may work in one population. We're learning what we can use for these patients based on experiences worldwide. The age in which we exist now when we practice allows us to share information real time from as far away as France to Australia to the US, and we get that real time by simple WhatsApp message. And luckily, all of us have fairly extensive networks around the world, and we share information to know what works and what doesn't work. Well, like what Dr. Singh says, we don't yet have a universal cure or a universally accepted treatment regimen. There are things that we can try for sure, that can help patients. Luckily, more than 80% of these patients do not require any kind of hospitalization. But for those that require hospitalization and go on a ventilator and stuff, the mortality is still unacceptably high.
So you did mention about the human resources. So at this point in time, do we have adequate human resources for, if we look at the trend that is happening around the world, and could we anticipate what could happen here in Guyana? Do we have that adequate resources available, both human and infrastructure and ventilators?
Okay. So
what's your thoughts on that?
I will stay away from a simple yes, no answer to that, but I'll probably provide the more composition type answer for it. Here's our challenge for human resources. If we do not have the right personal protective equipment, and we have patients who ought to not come to hospital, then come and expose staff of the hospital to potential infection, what we are forced to do is quarantine critical staff at home or in facilities. That takes away significantly from our manpower base. I can tell you recently when we had that, and this is public knowledge, patient who came to the emergency room, our case number 1, or index case, a lot of the staff in the emergency room were exposed to that patient, and therefore we lost a lot of nurses and doctors who had to stay home for that 14-day period. And if we continue along that trend, it will happen in the private hospitals, the public hospitals, and we are definitely going to be short of human resources. We are managing so far, and perhaps some of it is a false sense of security because we're not testing as many people as we should. And again, that's a resource challenge. As of a couple of days ago, we didn't have enough test kits to test everyone who may qualify for the testing. But as I read the news on a daily basis and I follow what's happening, it seems as though we're getting more and more up to speed with what we require for in terms of testing. So we should have a lot more test kits now available. It's about now developing the appropriate criteria for which patients to be tested. As it relates to ventilators, I don't believe currently we have enough for a mass casualty, but I also saw in the news that there are 14 new ventilators that are provided now. And so that's 14 more than we had 1 week ago. We don't have all that we need, but it seems like if we're moving in the right direction in terms of that infrastructural needs, in terms of the ventilators and so forth. I hope that answers
and I would like to
causing too much panic.
And I would like to divert this to Dr. Singh and Dr. Anthony.
I would like to add to what Dr. Carpen was saying.
As first case scenario.
I would like to add to what Dr. Carpen was saying.
About the same in the private sector. Go ahead.
What my esteemed colleague was talking about is the only tertiary hospital, public hospital in the country. There is breaking news that patients showed up at one of the regional hospitals with symptoms very suggestive of respiratory failure, and most likely because of this viral infection that we're dealing with. One was swabbed, one was not. There were 2 patients, but apparently there was no one skilled enough, from my reports, to be able to assist or wanted to assist to ventilate these patients. Hopefully there were ventilators available, but the skill set that Dr. Carpen is talking about that can, be attritioned because of quarantining As it is, we're starting with a very limited number of the appropriate human resource. I don't think we have, as a nation, we don't have many intensivists or internists or critical care personnel who can really adequately deal with these patients. In many developed world hospitals, you have staff pretty much waiting, ready for these cases. Not when a case comes in, then we go gloving and putting on personal protective equipment and so on. It's a case where you are ready, waiting for any eventuality. And I think we are a far cry from that in the regional hospitals. And mind you, if someone is getting very sick, as I said, this is a very rapidly progressive type of pneumonia. They develop shortness of breath and low oxygen levels and problems breathing very, very quickly. They wouldn't make it to Georgetown. They will want to go to regional hospitals, and that's the whole purpose of having the regional hospitals. But then if we don't have the appropriate personnel ready and waiting with clear intentions to carry out the duties, to adhere to the Hippocratic Oath that we all took to treat patients, then it may not work. And if these patients may not be able to get the kind of care they need at these hospitals, then they're all shunted to public, and that also overwhelms the system because the public hospital in Georgetown cannot handle and will not be able to deal with all the cases if we really do have outbreak, as we're seeing in next door Trinidad. Trinidad has many more cases than us, and they're already having deaths. The private hospitals now where we are, we're seeing that they're trying to screen patients, and some patients probably are being screened and rerouted to the public system, primarily because of logistics. I know, for example, one private hospital I spoke with today has 5 ventilators. Now, of those 5 ventilators, 2 are already in use for other patients. Remember, we're still dealing with the other subset of patients that we deal with on a regular basis, people who come in heart failure, heart attacks, regular pneumonias, and so on. So we're really resource challenged, both human, financial, capacity, and infrastructural. So our best way to deal with this condition is pretty much what many of even the less resource challenged countries have done, is we need to test more so we could identify people, those patients who have milder form of the disease, but it's equally dangerous because they're transmitting to the more vulnerable patients. And 2, to reiterate and re-emphasize and preach to our people, the population out there, that we need to adopt better behavioral patterns. We need to wash our hands, we need to practice social distancing, and we need to self-quarantine or self-isolate if we have respiratory tract symptoms and fever. And we have been preaching this for the past week or so, the 3 of us, on different programs, talking about, trying to get people to stay indoors, go out only if it's absolutely necessary, and to practice proper hand washing and so on.
Okay, so I noticed that in the United States, they are exploring twinning of ventilators. I know it's not approved, it's basically off the books right now, in which they're trying to put 2 or 4 persons on one ventilator. I would love to hear our doctor's opinion, personal opinion will be at this point, because it is, as I mentioned, off the books. What is your personal opinion on this? Could this be a practice that we can explore if push comes to shove?
In this country, we are often faced with scenarios where push comes to shove. And if we have to do it, we will have to do it. It's better to save a life and then treat the other things afterwards than to lose a life because you're hesitant to share a ventilator, for example, between 2 and 3 patients. We'll just have to do what we have to do. If push comes to shove, yet again.
Well, I think, hello?
Yeah, we hear you.
Yeah, I think what is important though is that while we are not seeing as many cases, we should use that opportunity to keep up our preparedness. And as you were saying, Mahendra, that the government is now procuring an extra maybe 14 ventilators. But from some of the projections that I've heard and modeling that was done, that is not going to be adequate. And what we need to do, because we cannot have just a centralized approach to treating patients, we have to decentralize. And one way of decentralizing is to use our regional hospitals. As far as I'm aware, many of our regional hospitals are not equipped to provide this level of care, and therefore we will need to equip them. We will need to make sure that they have all of the equipment that is necessary to provide this level of care, and of course the personnel. Right now, and if what we have seen at or heard about West Emerald Hospital, if that is true, then we have a serious problem. It just shows how unprepared we are, because the reports that we're
most of the cases were people from Iran.
is suggesting that there are 2 suspected patients with COVID that went there. And in one instant, the person needed to be intubated. And although you have skilled persons who were available to do it, they did not have the personal protection equipment. And therefore, apparently nothing was done. That person, according to the reports, is now dead. Now, something is grossly wrong with that. And I think if we can use this as an example, it shows that we are not ready for this epidemic. We have not made the preparations. We have not done the type of training that is necessary. And we really need to rethink what we are doing. We really need to urgently assess what is going on at the regional hospital level, how we can boost up that level of service so as to provide better care. Because Georgetown Hospital alone will not be able to provide the care that is necessary. You're going to be quickly overrun with patients if this goes really bad.
Yeah.
So, go ahead, Dr. Carpin.
Over the years, we've had that that paradigm that tries to tell us that advanced care can only be provided in Georgetown, and send everything, even the simple things, to Georgetown Hospital. And we have to be able as a nation to move away from that thinking and that model, because we have fairly large size hospitals in all 3 counties, and depending on population, there are other hospitals as well. Study hospitals should be able to provide top level care to the people of the Essex River Coast. The Amsterdam Hospital should be doing the same for Berbice, so Skeldon Hospital, West Dem. It doesn't all have to be shunted to Georgetown. The Georgetown Hospital actually serves not only as a tertiary hospital, but it's also like a community hospital for the Georgetown population. It also works as a primary health center for this population as well. We want to continue to do all of those roles as center.
And you see, the other thing that I think about is that we had our first, I think, around the 11th of March, that was confirmed. And to date, we are aware that there are probably about 5 cases. Now, that probably would give us a false sense that we don't have a lot of cases, but from anyone who have been following pandemics and so forth, there seemed to be a gap here in terms of how this infection is playing out in Guyana. And the reason why I say that, because elsewhere, whenever you have a positive patient, that positive patient would likely infect at a minimum, maybe 2 to 3 other patients. And so what we are seeing, just having 5 over the last couple of days, might not mean that it's only 5 cases that we have. The challenge that we, I think, the whole health system has faced is that they were not testing people who might have contact with this person. And if, according to our case definition, is established, if you don't have a laboratory confirmation, then this person cannot be considered as a case. The person might have all the signs and symptoms of COVID-19, but unless that person is also tested, and that laboratory test has confirmed that this person is positive, then you cannot count them as a case. Now, this is a serious thing because if at one point, when we just started the epidemic, we had 30 test kits. So a lot of testing wasn't being done. I understand as of about 3 or 4 days ago, we now have maybe about 500 or 600 more test kits that came into the country. And even that would not be adequate because as this unfolds, they're going to have more people that would require testing. And the only way we can know what we are dealing with is that we have to test people. And therefore, having more kits, it's a very important discussion. 500, 600, even 1,000 kits, if we have them, that's certainly not going to be enough as this unfolds. And right now, I understand when the first case came in on the 7th, a lot of those persons who were on flight, those persons probably got infected because we know family members who were in close contact with the first case, 4 of them got infected. We don't know how many other persons who were on the flight might have contracted the disease. We understand that the ministry was monitoring. They said they had about 179 persons that they were monitoring. But how effective is that monitoring? Are they going there? Do they have a team that would go out there? Now that they have test kits, have they tested anybody? You know, that sort of thing. We are not sure what is happening. So I don't want people to have a false sense because I know some people have been talking, well, we only have 5 cases and therefore we shouldn't be too alarmed. Well, we have 5 cases, we have 1 death, but we are not testing, so we don't know the of the epidemic that we have in the country as yet.
Let us look at the tests that we are using. We're using PCR test, correct?
Yes.
Yeah, I understand the test that we are using is a standard test that is used all around the world. It's the PCR, which we would check for the antigen.
Okay, so
Can't hear.
I missed that entire segment there just now.
Me too. I didn't hear anything. We're trying to talk about the types of kits.
Okay.
Hello?
Well, maybe you can,
Yeah, you
maybe
could
you
probably
can talk about it.
Sorry about
What type of
Go ahead,
So
sorry
far,
about that.
the main type of kits that we have here, the ones I'm aware of, is the PCR type testing. There also, I just read today that rapid kits were FDA approved.
Correct.
In where you can have results within 45 minutes. If these are FDA approved, then those can be implemented, but I don't know if those are the ones we have now. The initial set for PCR testing though, because I was involved in having a patient tested with the first set. Now you can test for the PCR, which really picks up the antigen at around 3 days after infection, or they have an antibody test, which picks up the antibody at around 7 days after infection. What the rapid kit does, I'm not sure.
At some point, we have to look at, you know, whether or not it's feasible to have a centrally controlled testing protocol, or if we need to involve the private authorities and the private labs as well, and make it a reportable result. To rely solely on the Ministry of Health to coordinate and quarterback the entire operation may not be, you know, the most effective way of going about this, given the lack of resources. And so we have to examine all of these options that are on the table. I know, you know, countries that are more developed have a centralized healthcare system where single payer, universal healthcare kind of stuff. So they're able to track these things from an epidemiological point of view much easier. But you can imagine our challenges if a lab in Berbice, a lab in Essequibo, a lab in Georgetown does these tests and they're not reporting it to a central authority, then it becomes difficult to do like contact tracing and so forth. So even though they might provide benefit to doing these tests in the private sector, we have to look at making this, when it does happen, and I believe that it will, we have to look at this as a reportable result.
Mm-hmm. But with the kind of technology that we have today, I mean, I can see that actually being not so much of a difficult task in communicating results from across, you know, the country, just like in many other countries. Right now, as large as United States, they're easy to communicate those information. So maybe we need to have some more testing sites available, because if you have to wait for a test to get from Essequibo to Georgetown, that's already one whole day just by transporting.
And exposing themselves
Correct.
to the public.
So far,
correct.
We've been addressing this whole issue, like if it's a Region 4 issue. Region 4 already has a challenge. But this is a national issue. I haven't heard anything in the news or on social media or anything at all about effort in Anna Regina or in New Amsterdam or Crabwood Creek. I haven't heard anything at all. And those people travel just like anybody else. And so they could import these cases and then have community spread. So, you know, we're a little bit, as far as I'm aware, we're a little bit behind on the rest of the country in the effort to combat this disease.
I think I read in the dailies, one of the dailies today, that Region 9 and Region 10 has imposed some type of curfew to limit movement within those regions.
But even if you limit movement, you still have capacity to test. And I don't think they have capacity to test. Region 9, for example, the regional hospitals depend on sending patients across to Bonfim and to Bovista. And now that the border is closed, those patients would have to find somewhere else to go. So that is a concern, a big concern. And again, I'm not sure whether or not they have testing capacities there. The ministry ought to put some mechanisms in place, because one fear, and that's why probably the borders were closed. I understand there were a patient in Bonfim that tested positive. And so out of that fear, because apparently that patient was also in them. And so there's some amount of panic. But the only way you can honestly deal with this thing is to make sure you have test kits up there, and the persons who would have been in close contact with this patient should have been tested. As we speak, I don't think they have deployed any sort of testing to let them to be able to do this. So we can't just run on, hearsay. We got to work with the science that we have at our disposal, and that is we have to provide testing.
Okay, I want us to get our audience involved in the discussion. So I will ask some of the questions to our doctors this evening. I have Ashley Anthony is asking if we can confirm how many kits we have currently in Guyana. And she also wants to know what percentage of persons were tested so far in Guyana.
A hard question, Ashley. I know as of when we started this process 2.5 weeks ago, we had 30 test kits in the country. I'm not aware of the official number of kits that are now available, but we see every day or every couple of days in the news that we're getting more. And as of recent, I saw 700 new test kits. Now, those are just the kits available. In terms of who are tested or the percentage of patients who presented with any kind of symptoms that were tested or what criteria is actually being used, I must confess being in the dark on those.
If I may add to what Dr. Carpen is saying, which is totally accurate, but of those 30 kits, the way it works, when you test 2 patients, a third is used as a control. So the first 30 kits weren't really used for 30 patients. It probably would have been used on maybe 15 to 20 patients, because one after every 2 or 3 has to be a control. And this was explained to me by someone who is really high up in making decisions who get tested.
And in addition to that, they first have to do a screening test. And if that screening test is confirmed, they use the same type of test to do a confirmatory test. Right. So basically you're using 2 kits, one for screening and one for confirmation. And once that is done, then you can say that this patient is positive. On the other hand, and maybe that's where we need to come up with our own testing guidelines, we can probably use one of the rapid kits that are available. And we can evaluate them, get our experts to evaluate them, so that we can use the rapid kits as a screening kit. And then if that shows positive, then you use the PCR for the confirmation. In that way, it would
plausible, very plausible.
Yeah, it would probably be cheaper, and we'll be able to screen quite a lot of people and make it more accessible. But PCR, as we all know, it's expensive, and therefore, if we're using PCR both as screening and confirmatory tests, that's going to be problematic. And I don't know that we might be able to sustain that. Right now, the kits that we have, those are donations. It is also time that the government step up and buy kits, because those kits, the 30 plus maybe the 600 or 700.
I think we received 1,000 kits from WHO. I think that was what the ministry announced.
Right, but it's
1,000 more kits. So it's somewhere around 1,800. Yes, all donations, all donations.
So we
all
as
donations.
a country, we need to step up, make sure that we buy kits, and that's a that is in demand.
Yeah, and I think
have enough.
And I think since China has opened up again to production, they have been rapidly producing a lot more of these kits, and they are already available on the market also. I have another question here. It's from Preeta Smith, and she's asking if we, since we have the facilities to conduct PCR testing, why can't we create our own kits?
We don't have the facilities to conduct PCR testing. It's the kits that really are PCR enabled kits. and this is done so far only at the National Reference Lab. Do we have the capacity to develop our own kits? I'm not sure. Maybe Dr. Carpin, who is in the public health system, may be able to answer that.
I'm not sure. I must confess, I don't see why we can't, invest in getting the right personnel and the right resources to do that, because as we move more and more into the modern era, the need for PCR testing for various things will become more and more required. So I think this is something we definitely need to spend some resources on to establish.
Because India is developing their own kits now. And
the other challenge for that also is that we want to make sure that there's some level of standardization, right? So the kits that are coming in, they have gone through some sort of standardization. They're WHO certificates, so we know that they're adequately vetted and so forth. So when you diagnose somebody, you're actually can be certain that they have gone through the rigors of trial, and therefore we are certain that this person is positive. If we are going to, and if we do have the personnel and resources to develop our own kit, I think that is going to take some time. And then we'll have to go through that validation process, which would also take a lot more time. So at this point in our response, it might be cheaper to buy the commercial kit that the WHO is recommending. But my advocacy, and I think some of the other people that I've been talking to, is that we also need to start exploring rapid kits. The ones that Dr. Singh spoke about, where maybe in 40 minutes you can know whether somebody is positive or not, and then use that as screening and then go on to do the PCR as your confirmation. Because PCR kits and the whole process takes a couple of hours to make sure that you get the results.
Okay,
so
Ramesh.
For us to consider.
Okay, Ramesh Duku mentioned that at least one private hospital had pledged support using their own contacts to supply from overseas these same kits. So I guess he's wondering why they're not having approval to bring in these kits. I guess that's what Ramesh is asking.
I think what one of the things that we know, one of the private labs have said to us that they take the sample from patients and to send it abroad, send it to the United States and get the sample tested out there. So I would probably have to make that service known to the general public and to set up some process by which person can go in and the sample can be taken off and then sent off to the US for testing. So they're not going to be testing here. My understanding is that they'll take the sample and send it to the US for testing.
But testing, that sounds plausible, but there might be logistical problems there in the sense that there's degradation of the sample within 4 hours unless it's stored at a certain specific temperature, usually very cold temperature, if I remember, -20 Celsius. Otherwise, you'll have degradation of the sample and hence lots of false negative results. So getting a sample to the States within 4 hours is obviously not practical. Yeah. And storage may not be a very simple thing either, but the whole idea sounds very plausible.
The other thing maybe that we can look at, as was mentioned before, is that the private sector, the private hospitals and so forth, maybe would want to invest in PCR machines and to make their own arrangements so that they can get those tests in. And I recently was happy to see that the GRA has said that they're going to waive whatever taxes were associated with the importation of these medical materials. So whether it's kits or things that are necessary, personal protection equipment and so forth, that they would no longer attract any taxes. I think that's a good thing. And if you need machinery and they're going to waive the taxes, maybe it's time that some of the private sector entities consider investing in some of these types of equipment.
Yeah, so hi guys.
Hello. Hi, Ramesh.
Yeah, what's happening? Yeah, cool. I just want to bring you up to date with a couple of things. You know, the private labs and the private hospitals, they're raring to get involved, but we seem not to like have a channel where this conversation can take place. I spoke to Mr. Nagamutu, who invited the Private Sector Commission to sit on the task force. Frank is aware that we have met consistently for the last 4 days, and there's a lot of impatience regarding when are we going to be heard at this task force? Who are we going to be meeting with? Mr. Nagamoto this afternoon clarified some of that for us. But over the last 2 days, we've been invited to speak with the budget director. We've had a very fruitful conversation with her. She's now aware of exactly how the private sector can contribute. I can only at this time speak for 1.5 private hospitals. One has agreed to come aboard, and the other one is raring to come aboard, but clarity is being sought. And we were unable to provide that clarity. We're still hoping to meet with the other three private hospitals to get their views on what's happening. There's a lot of capacity in the private sector that can be utilized. So I think we need to pool all of our resources, public and private resources, to be able to battle. But there needs to be a national consensus across lines, across private and public lines, across political lines, across regulatory lines, and that kind of thing. So I think this conversation is extremely positive. It's a positive development. I want to commend Zulfi, I think, who played a great role in making this happen. So that's what's happening. The economic measures proposed by the private sector has been not embraced, but has made a lot of sense, it would appear, to the budget director. And we hope that she can put that forward to whoever is going to make these financial decisions. The outlook for funding for the COVID-19 efforts is not as positive as we would like it to be. Many of the donor agencies, apparently, they're sort of looking at the existing funding that they have to Guyana to see how they can reorganize those to come up with funding for COVID. But I am optimistic. We all have to be optimistic, and I believe the budget director and her staff are working assiduously to find funds. Today we had a meeting with the Minister of Business, the Ministry of Business, and we told them everything I'm telling you. Why we'd like the private sector to be more involved, how we can be involved. We spoke about future supplies of flour, future supplies of rice. We spoke about many other constraints, removing constraints to importing chemicals, removing requirements, bureaucratic requirements, for example, to go to the Chemicals and Toxic Board, which takes a couple of days.
Mr. Duku, what I would love to share with you right now is that next week we're definitely having a follow-up conference call, and we'll be looking and we'll be focusing on the impact this pandemic is going to have on the businesses in Guyana and the economy as a whole. And I'm sure, very sure, that we would need you to be one of our experts on that panel to discuss where we're heading. So I'm definitely going to be looking forward to your views when we have that conference call set up for next week. But
Sure,
I just
sure.
noticed that we're running out of time. I would just want to get one other very important question in. And Danny is asking, are we engaging epidemiologists as part of our efforts as a country? So do we have epidemiologists on the task force right now? Any of the doctors could go ahead and answer for me.
I'm
That
not
would
sure
be
if
from,
they-
yeah, go ahead, Frank, go ahead.
Yeah. Well, I'm not sure all the members of the task force who they are. Certainly, we do have epidemiologists in the country, and we do have persons who are working with the ministry who have training in epidemiology. You have people at the University of Guyana and so forth. So there are people around. How are they engaged, and what are they doing? We are not sure. And so simple things, if we can't get basic information out, if we're not doing things like contact tracing, which is all standard public health measures. If you have somebody sick with an infectious disease, you have to do contact tracing. And if we're not doing those effectively, we have to take a pause and see what are we not doing right.
Right.
Is it that we don't have enough personnel? Is it that we don't have equipment? I don't know what it is, but we have to assess what we are not doing right, and then ensure that we are able to build that capacity very quickly so that we can do the kinds of contact tracing and other things that are necessary. Very soon, we will not be able to trace anybody. And the reason being it would be too much, right? So then you can't go trying to contain anymore. You will have to start thinking differently and adopt different sets of measures. So at this stage, there might be some hope of doing certain things. And I hope those types of public health measures are being followed. But if we know that, for example, we have people that are in, you recall that about 2 days ago, I think a plane came in from Barbados. All those persons who were on that aircraft was quarantined. And when you look at the conditions in which they're being kept, that itself, if there's one positive among them, then everybody is going to be infected, because all the nice messaging that the ministry has about social distancing, they themselves are not putting it in place in the facilities that they're running. And if we're not doing that, then who's going to believe what we're preaching? So when you look at photographs coming out of that quarantine facility, you have beds that are within 2 feet of each other, and a whole set of other things that from those photographs, you can see that they're totally wrong. They're not adopting what epidemiologists would have advised or what public health specialists would have advised. So again, we have to rethink some of the things that we are doing. Not that having quarantine is bad. It is an essential way of managing epidemics and self-isolation and so forth. These are essential tools that you have when you're managing epidemics and pandemics and so forth, but we have to do it properly. And so far as some of the things that I'm seeing, it is not being done properly.
Okay, but
yeah. In closing, we are seeing evidence now that this may be cyclic. So it probably will be there's an antigenic drift, some mild mutation or so forth. That means it's likely that there might be another season of this pandemic. In closing, docs, what systems do we need to start putting in place now? And this is a message to the task force. what systems we need to be putting in place right now to safeguard the health of our fellow Guyanese?
Well, my take on that is, first of all, let's manage what we have, what is coming up to us, what we anticipate would be coming. And to do that, we need to ramp up what we are doing at the health response that we have. So from getting more kits in, to getting more personnel to do the testing, to prepare our institutions like regional hospitals and the national hospitals, and then also to have excess capacity somewhere in the case that we have so much overflow that the national hospitals cannot cope. So we have to start thinking in those terms, and we need to rapidly start doing that. So test kits, we have to get far more. Even if we have 1,000 right now, that's not enough. We have to explore different ways of testing. We have to be more aggressive with testing people and getting those tests out there to people who are the suspected cases and so. So my thing is that I'm not even thinking about whether you will have another peak. Our peak hasn't, and we are not doing that well. I know that I've spoken to some of the docs and nurses in some of our public institutions, and they're complaining that some of these institutions are rationing the personal protective equipment because we don't have. Now, that's a sad state we need to get, and we need to buy them. We can't depend on somebody who can come and give us a nice generous donation. We as a country, we got to set aside money and go and buy these things so that we can protect our frontline workers. These are health workers. Just as Dr. Mahendra was saying, if in our first case, if a lot of our docs had the protective gear, many of them would not have had to go and be in quarantine or self-isolation, because that happened because they didn't have protective gear at the time. Now, maybe they weren't expecting this case, but now that we know, we have to ensure that our health workers are protected, or we'll have a serious problem where we wouldn't have enough health workers to take care of the people who are sick, because those persons would have to be in self-quarantine.
Absolutely correct. Dr. Carpen, you want to share your views?
Well, we know what we have done well in this initial phase, and we know what we have not done well. Now, what we need to do is to learn from this experience so that we are prepared for the potential of a second wave. We have seen that patients can develop reinfection after the first presentation. It's not everyone, but it happens. We have to be prepared to do what we are doing now in a much better way. We need much more resources to test patients. And when you test them, to isolate them properly and to be able to have proper logistics flow from the time a patient makes a phone call. I know we had a lot of challenges at the beginning when people are calling the hotlines. They were not being answered, or when they're answered, they were not happy with the advice that they were given. And there are lots of challenges. So all of these experiences can teach us something, how to be better prepared for the next time this happens, which it very well might happen.
So, Dr. Singh, you get the last.
If I may add, in addition to what my colleagues have said, is that to better deal also with a tragedy or a disaster like we're having a pandemic of COVID-19, we need to improve on the public-private partnership. We in the private hospitals have very blurred lines as to how to even go about testing a patient. For example, I practiced for years in the US. If I wanted a test done, all I have to say is I want a test done, and it gets done. Here, when I was involved in testing a patient who was an expatriate, I had to literally do all the work myself. from taking the swab, calling the reference lab, coordinating with the reference lab, coordinating, getting results. When I called for results, I was told the reference lab is closed. The person was going home. I had to wait. That was a Friday afternoon. Now I have to tell this multinational corporation, oh, our reference lab is closed, so I have to wait on Monday for the results. I mean, it was pathetic. So I had to wait on Monday to get a result for something that was done early Friday morning, and I could have had results then, although I was promised. I'm alluding to a statement you made earlier, Melissa, saying that with all the technology, it's so easy for us to communicate to a central authority of results and so on. But here it is, we were both in Georgetown, 2 hospitals literally 5 minutes away, and I couldn't get results within 72 hours, all because of not having a free-flowing, well-delineated public-private partnership or flows, lines that, you know, we can follow and definitely know who to test, how to get the sample to the reference lab and get results in time. So something that seems very simple became a logistical nightmare. And these are the little challenges that we have in addition to the major challenges in terms of protective equipment and resources and so on that we face. So it seems that we have a lot of inherent obstacles in the system that needs to be sorted out. Thank you.
Okay, thank you very much, Dr. Anthony, Dr. Carpin, Dr. Singh. Thank you so much for spending this hour plus with us. It was very informative, very insightful, and I'm sure we'll be calling on you again sometime soon to share your knowledge and give us some more insight into where we are right now in this pandemic. To the rest of the AmCham family and friends who are joining us, thank you for being with us this evening. And please keep abreast with our Facebook page and other social media sites so we can keep you up to date on the other conference calls that we will be having. We will definitely be having one next week again, and we'll be looking forward to seeing you once again. So have a good evening, everyone. Please stay safe.
Thank you. You too.
Bye.